And even though I may switch to a longer needle, I'm going to start with the shorter needle because I just have more control. And 1, 2, 3, a little stay. The longer needle sometimes is a little bit harder to maintain the same depth. So now I'm subdermal, essentially at the top of the fat in that area. And I inject as I advance, partly because the lidocaine helps numb it up as we go. And also I think it bruises a little bit less, maybe theoretically, because it pushes the smaller veins at least out of the way. And then I'm going to fan it up. I want to go towards that depression, under the eyes, while we get the malar separation at the same time. And when you're deep enough, you really don't see it at the surface. Like I can push the skin and I don't see where the filler is. If I'm too superficial, intradermal in here, it'll tend to all move as like a little plate or a section where it doesn't look natural when you talk. Now I'm going to switch over to a 27 gauge 1.5 inch needle, and then I prime it by just making sure there's no air in it. And now it should be fairly numb where I've already been. And what I'm going to do is I'm going to go up underneath the suborbital area, and I want to lift this area out. And I want to I'll have my finger over the orbit part of the time, because that's where I can tell where my needle is. And we're going to try to just always kind of use the same puncture if we can. Just less needle marks. No, and I'm not injecting integrate, I'm just advancing my needle. And what I want to do is get it up to the point where I have my finger on the orbital rim, I'm injecting deep. And when I can feel the very tip of the needle underneath my fingertip, then I can inject a little bit. I inject a little bolus here. You can kind of see it fill. And then I can feel a little, kind of a rubbery little bleb. And I just mold it with my finger down. You can even push it up a little bit to get it all the way up to the top of that orbital rim. But we undercorrect because the hyaluronic acid fillers attract water. So over the next few days, if you correct to 100%, they can look too puffy. So we correct usually to about a 70% correction. So you still see a little depression, and you have to convince the patients that that's okay, because over the next couple days it'll get better. And then I'm going to use the same injection site and go back in and just put in little boluses all along the orbital rim and then mold them down. And by injecting this much, by injecting this far below the orbital rim, it bruises less. If I try to inject too close to the suborbital area there's so many little veins, so it's really easy to give somebody a black eye. But I'm going under most of those veins. And you can do it with a 30 gauge 1/2 inch. If I'm just injecting under the eyes and nowhere else, I'll just use a 30 gauge 1/2 inch or a 28. But when I want to really use the one puncture wound for most of the cheek, I'll use a 27. So we'll come back and redirect. I want to always be underneath this fat pad. I don't want to inject and make it more prominent. And you can kind of see it just fill there. Put a little bit more over here. Is that kind of pinchy there? Sometimes you get a little sharp pinch when you're near the bone. And so much of it is by feel. You kind of just go real slow and gently and kind of march it up over the edge of the orbital rim. So usually with each little bolus is probably maybe 0.05 cc, just enough till I can see a little bulge when I inject it. And then, of course, I'm going to go back and add a little bit more if I see any areas that look depressed when I'm done. It's just an area to be a little conservative. And the main problem I think we have injecting this area is injecting it low, like injecting it when we go to inject. If we don't inject in the depression, but we inject here, it'll just accent the depression. And so, and yet people have a tendency when they first get going in that area to inject too low because they're just afraid to get close to the eye. And I think because we're not ever going inside that orbital rim, we're going right on top of it, we're not going to ever be close to the eye. Now I'm using a 27 gauge hyaluronic acid here. Most of the time I probably use a 30 gauge thinner filler because of the tendency to attract water. But because I'm using the same syringe to go into the cheeks that I am under the eyes, I don't want to waste a 30 gauge filler in the cheeks because it's just not robust enough. I just tend to be more conservative around the eyes because I know they'll plump up nicely over the next couple of days. I don't use anything but hyaluronic acid around the eyes because if it blocks the lymphatics, people will end up with a puffy eye and you can't dissolve it. Where if they just get a puffy eye and I've used hyaluronic acids, that I can go in and dissolve the filler just over the surface of it and get rid of that puffiness. Plus the skin's so thin there that some of the thicker fillers that aren't gel fillers tend to be a little bit bumpier there. I can just go in from here and get this outer part of the suborbital depression. Or when I'm doing the cheeks, I can come in from over here and get it. So that's what we'll try on this side then. The 27 at 1.5 inches sometimes can be a little bit harder to keep at the right level because they have a tendency to bend so easy. You can kind of see where it's bulging it up, and my finger's right on the edge of the orbital rim. We're going to inject some Juvederm underneath the eyes here in the suborbital depression area. I like to use the 30 gauge hyaluronic acids there, either Restylane or Juvederm Ultra, because they don't pull in as much water as, say, Juvenile Ultra Plus. They don't look as puffy. I still undercorrect to about 70% in here, because even with a little bit of water attraction, it can look too puffy if you go for 100% correction. I also tend to go in from below, because I can get in here and fill it without a lot of bruising. If I get up close in this area, there's just so many little veins, it's hard not to bruise. I still occasionally get a little bit of bruising down here, but if I can try to do it with one puncture, at least it's just the one bruise usually. So here's a little pinch. In this area, I don't inject antegrade like other areas. I tend to advance my needle up until I feel the tip right below my fingertip. And you see where it is, just right there in the suborbital area. But it is deep. Not always below the muscle, but definitely not much above it, or you'll see a bump. And I inject little depots, maybe about 0.05 cc's each. And you see that little lifting of it there. I'll pull my needle back a little bit and then advance it again without injecting until I get to where I want to be, and then I'll put in another little depot. We're going to go back and palpate those, and that'll soften them down. I want to go a little bit more medially. This is the Juvederm with the lidocaine already in it, the XC, which is nice because there's no extra fluid added. So I know I don't have to overcorrect. You just palpate it down against the bone. So I'm going to go through the same puncture site. I want to go under the fat pad there. So I direct deep. I don't inject antegrade. I kind of come up underneath it really slowly. And then put in another little depot there. And I go back and then redirect. Go a little more anteriorly, staying deep. And then again to get all the way over to the lateral canthus area. And if you're deep, you tend to miss on any of these veins that swing around the lower orbit. And I just go in and you feel each little individual bleb down against the bone and palpate it down until it feels flat. And if you have to, you just go back in and can add a little bit more. And I want to get a little bit more over into the far lateral. You just go very slow. Sometimes if you do tap the bone, if you're going really slow, you can back off. A little bit more. I want to add a little bit more where that shadow is, right up at the top of the lateral orbit there. You just want to be careful not to inflate this malar mound. And with the lidocaine in it, you can palpate it pretty firmly and it doesn't hurt. Let me just kind of look at you like that. Okay, good. I'm going to put a little bit more towards the medial aspect there. Is this hurting you at all?
Mm-mm.
Okay, good. I'm just going to push a little bit forward, bunch the skin up a little to get it up into that area without making a new puncture if I can help it. And usually you can go through the one puncture and get the entire orbit and hopefully not end up with any bruising. And let me just see a little bit more. Good. At this point, then, I'll usually hand the mirror to the patient and have them look at their eyes, letting them know that they're going to still see a little bit of depression still, especially with Juvederm. And that's going to soften up and actually smooth out a little bit more over the next few days, because we don't want it to be completely even with the surface, or it may look too puffy in a few days. Good. Just want to put a little bit more up in the lateral part there. Gosh, it's hard to even see where the puncture is on you because it doesn't bleed. You have no blood. That was so convenient. If you ever hit any resistance, you always want to back up a little bit. Sometimes you're actually under the muscle, where the muscle is connected to the bone. So you don't want to really fill it in too much in that area, or it starts to look like a shelf. I'm going to look at you that way. You can see it's almost going to be a whole syringe on just the one side. I think that's about an average amount I think we use if we need to do the medial to the lateral suborbital depression. It usually will take about a syringe on each side. If it's just the medial suborbital depression we have to fill, we can sometimes do both sides with one syringe.